Good afternoon. Good afternoon. Thank you. My name is Alden Landry. I'm the Faculty Assistant Director for the Office for Diversity, Inclusion, and Community Partnership. And I want to welcome you to our Equity and Social Justice lecture on Asian American health. I am excited to hear the presentations from our keynote presenter as well as our panelists and closing comments from our commentator. But just to give you a little bit of background about who is in attendance, we have representatives from all across the Harvard institutions. We have representatives from BU, MIT, New England College of Optometry, Northeastern, UMass Lowell, UMass Boston, and UMass Medical School, as well as our hospitals, BIDMC, Boston Children's, MGH Brigham, and Dana-Farber. We have colleagues coming from a number of community organizations here. And I just want to say that this broad representation represents everything we're trying to do with these equity and social justice lectures. This is our third year doing the ESJ lecture series with the goal of bringing dialogues and conversations that target the Longwood community as well as our communities in the greater Boston area. The series serves to provide context for the historical, current, and future state of equity and social justice in the healthcare system and engages and equips participants with tools to really take action and make effective change. Our ESJs have focused on 4 areas, one being historical context, 2, cultural and environment, 3, health disparities, and most importantly, leadership and skills development. The format for today is pretty straightforward. We're going to have, and I'm predicting it already, a wonderful keynote presentation by Dr. Chang, followed by a brief Q&A, and then we're going to bring up a number of representatives to lead a panel discussion that's going to be moderated. And then after that, we will have a closing conversation. We invite you to stay involved, to ask questions, and to network both with our with our panelists in our keynote and also with each other as we close out the day. We do have some refreshments in the back. If you do need to exit to go to the restroom, please use the back door because we want to make sure that we have our attention focused on our presenters here at the front. Any questions before we get started? Seeing none, I want to open it up and bring up our keynote speaker. So Kimberly Chang is a family physician at Asian Health Services in Oakland, California. Previously, Dr. Chang was the inaugural clinic director at AHS's Frank Chang Medical Center and provided care for many commercial sexually exploited children. She's worked in this area on a number of levels, including on a national level, where she serves on the National Advisory Committee for the Sex Trafficking of Children and Youth in the United States and is the co-founder of Heal Trafficking. In 2015, Dr. Chang completed the Commonwealth Fund Fellowship in Minority Health Policy here at Harvard. Round of applause, welcoming back one of our own. She was elected recently as the Vice Speaker of the House on the Executive Board of Directors for the National Association of Community Health Centers in 2018, and recently appointed to the APHA's Committee on Women's Rights. She received her undergraduate training at Columbia University, her medical degree from the University of Hawaii. She specialized in family medicine at the University of California, San Francisco, and received her MPH from Harvard T.H. Chan School of Public Health. With that, I'd like to bring up Dr. Chang.
Thanks. All right, let me turn this on. Are we starting the time? Are we starting the time? All right, thank you, Dr. Landry, for that introduction. I see many friends, and I've met new friends today, so thank you all for being here and taking time out. Oops. Are you guys queued up for this? Well, let me just start by saying that I wanted to thank the Office of Diversity, Inclusion, and Community Partnership with Dr. Joan Reed, who's coming later, Teresa Carter here, Ying Wang, Christine Colosino, who's outside, and Jackie Wright. They've been really wonderful in spearheading and organizing this presentation for today, as well as Dr. Landry. So, speaking of diversity, inclusion, and community partnerships, that's based on exclusion. So I'm going to take some time to actually focus not on inclusion, because you guys do that every day, all day, but I'm going to take some time to focus on exclusion. Exclusion, if you will, is the basis and the foundation for inequity and disparities in the United States because it's all about policy. Who's left in? Who's left out? It determines who thrives, who merely survives, and who's despised in America. So with that, I'm going to move on to talk about a little bit about some of my family history, the living memory of my family. This is my great-grandfather. He was born in the year 1900. That's 2 years after the Chinese Exclusion Act. That's 2 years after the United States annexed Hawaii as part of the United States, a mere 18 years after the Chinese Exclusion Act of 1882. So when I talk about living memory, I talk about my great-grandfather, my gongo, because he helped raise us. He died in 1997, in my second year of medical school. So he was really a big part of my life. He spoke Pidgin English, some Cantonese, some Hawaiian. He was born to a part Hawaiian woman and a Chinese immigrant laborer in the year 1900. And I remember him. I remember his stories. I remember him growing up. I remember him taking us around, picking us up from school, and sharing with us what it was like to be growing up in Hawaii at that time. My living memory of my family is also my grandmother. She was born in 1923. She's still alive. She's still going. She's 95 years old. And she was alive in this time of exclusion as well. So you hear a little bit more about that. And this is my mother. She was born in 1945, right after the World War II. So when you think about living memory, think about these policies and these exclusionary ways of stigmatizing people are not so far removed from today. They're in my family's living memory and in your family's living memory. All right, so with that, I want to focus on exclusion, not inclusion, because you'll hear about that from everybody else. So let's talk about exclusion and a historical review of that. 1882, all Chinese were excluded from coming and becoming citizens in the United States. The Chinese Exclusion Act of 1882. Many of you know about that. Show of hands. How many of you? Everybody knows about that. Did you know that this was not the first anti-immigrant, anti-Chinese legislation in the United States? You thought it was the first, right? Okay, the first one, so 1882, Chinese, all excluded. The first one was actually in 1875, the Page Act. In this act, in the Page Act, they determined that all Oriental women would be excluded for coming to the United States because they were assumed to be prostitutes, and they were assumed to be associated with disease, public health disease. So the law was coded in health, but it was really racially based. So 1875, the first time there was any legislation on anti-immigration, the first time that the United States closed its borders, the end of open borders in the United States. Oriental women excluded in 1875, all Chinese excluded in 1882. Between 1888 and 1892, there were several legislative restrictions that were placed in policies. And this was the first time, this era was the first time the United States started tracking people with photo identification. So it was required that all Chinese living in the United States needed to carry a photo ID, a certificate, on them at all times. If they didn't, they could be deported. And this also applied to Chinese in Hawaii. So Chinese in Hawaii, when Hawaii became part of the United States in 1898, with the illegal forced annexation of the Kingdom of Hawaii, all Chinese living there were deemed to be United States citizens. However, these legislations, these acts, restricted them and said, you still need to carry these identifications. It was applied to Chinese only. And here's an example. You can't really see it that well, but on the top it says return certificate, lawfully domiciled Chinese laborer. This is my great-grandmother on my father's side in 1934. So they had to carry these around with them at all times, or they could be subject to deportation. First time photo identifications were needed in the United States, and the first time that the government started tracking people. All right, so we're restricted now. Even people who are here as citizens, even people here legally. 1907 to 1908, the Japanese were coming as well. The Japanese were here, Seiji. and in this era, in these 2 years, the United States was kind of scared of Japan. They were a powerful country, We didn't want to go to war. And so they made a secret agreement with the Japanese government that would limit who and how many people could come to the United States. So the Japanese government would take care of it. They would issue the visas, and they would say so-and-so could come or so-and-so couldn't come. So that was how they regulated the Japanese. All Japanese women could come at that time to marry Japanese men in the United States at the time. So I guess, Japanese, they're sort of okay for now. We'll let you in because you're a powerful country, and you can come into the United States. All right, so 1917. Anyone know what happened in 1917? I just learned this. I talked to a professor of history at SUNY Binghamton. He was really great, and he schooled me on all this. So 1917, the Immigration Act of 1917. I'm just going to show you what happened. The 1917 Immigration Act. This was an immigration act that was supposedly not racially coded. It was geographically coded, saying that anyone in these purple areas from this geography could not come into the United States. So it's not racially based, but everybody knew it was. So what countries are, go ahead, participatory. What countries are excluded here? India. Nepal. That's it. Malaysia. What else? Southeast Asia. Afghanistan. Nepal, Burma. Southeast Asia, South Asia, all these Pacific islands. Now this little yellow part, that's the Philippines. They're kind of not in this Asiatic barred zone. Why do you think that is? What's that? What's that? It's a U.S. colony. It's a colony of the United States. So we'll get to that in a minute. So they're a colony of the United States, and so they're kind of left out there. Also, the United States needs workers, right? The United States needs laborers. Who's going to do the work? All right. So basically, 1917 happens. India, Bangladesh, Burma, Pakistan, Southeast Asia, Pacific Islands, basically all of Asia, except up here. What's Japan, Korea? Okay, so they're kind of out of that. All right. So all these places excluded. 1924 happens. 1924, two things happens. The United States, I guess they decide, well, the Japanese were sort of okay, but now we don't really like them. So in 1924, two things happened. One, there was a Supreme Court case. It's called the Ozawa versus the United States case. And in this case, a Japanese man was residing in the United States legally for 20 years. And he said, hey, I want to naturalize to become a citizen. And it went all, because he said he's not, he said that he was basically a freely associated white person. So it wasn't challenging the constitutionality, it was challenging the fact that he associated himself as being white. And so in this court case, he lost. So he is deemed not to be white, so he cannot naturalize and become a citizen of the United States. With this Ozawa Supreme Court case, a new category of people was created, aliens ineligible for citizenship. So that was the result of the Ozawa case. Japanese living here in the United States could not become citizens. A second thing happened in 1924, the 1924 Immigration Act. And this is also known as the National Origins Act. And in this National Origins Act, basically, it established quotas from countries of people that could come in. The quotas were set very low at 100 people. And then it excluded categorically anyone who was deemed an alien ineligible for citizenship based on that Ozawa Supreme Court case. So what does that mean? That means Japanese and Korean excluded. Okay? So I guess they rethought their Asiatic barred zone map and said, wait, we're letting too many in. All right. So then 1933 happens. I talked a little bit about the Filipinos not being a territory, and let me just get this straight here. So what happens with those territories? The Philippines, Guam, American Samoa, and let's throw in Puerto Rico as well. for that matter. They were all U.S. territories. They're all island nations. And these people could come to the United States, but guess what? They weren't able to become naturalized citizens. Why? Because they weren't immigrants. The United States creates a new category called nationals. Nationals are the territories. They can come and actually be present in the United States, but they can't become citizens. So that's all the Pacific Island nations and Puerto Rico. So another way people are excluded. In 1933, the Tidings-McDuffie Act is passed, and in this act, in exchange for independence, there's an agreement between the Philippines government and the United States government to limit immigration from the Philippines to the United States, setting the quotas at 100. So now the Philippines will regulate their population and not let them come to the United States in exchange for the independence from being a territory or a colony. So the Philippines are not excluded. All right, what happens in December 7, 1941? What? Pearl Harbor happens. Okay, so the World War II is happening, and I guess the United States really decides they don't want Japanese people here. So Japanese American citizens, in Executive Order 9066, excluded internment camps. So, you know, the basis for exclusion in the United States of Asian Americans and Pacific Islanders, and then the illegal annexation of the Kingdom of Hawaii under force and duress, you know, is the basis for a lot of inequity and disparities. That is what I would submit to.
Here we go. I didn't push that.
But we're not, all these legislations have since been repealed or passed, so let's go through that. Was it a progressive turn? Or was it just because we needed allies in World War II? I think it was more because we needed allies in World War II. We needed countries that were allies that were in the Asiatic Barred Zone. So in 1943, with the Magnuson Act, the Chinese Exclusion Act was repealed. So Chinese could now come in and become citizens. 1946 to 1947, that act is known as the Luce-Suller Act, and it lists restrictions that keep the quotas at 100. So prior to that, only 100 people could come. It keeps the quotas at 100, but it lists the restrictions from people to naturalize and become citizens. Now all Chinese in the U.S. can apply and become citizens. 1952, the McCarran-Walter Act. This is the first year any immigrant can possibly become a United States citizen. And then 1965, the Hart-Celler Act. This is the one that has really shifted the demographics of the United States because it removed the national origins quota from 1924, which kept the immigration at 100 per country from all these Asian countries, and then put a standard quota for all countries across the world at 10,000. It also allowed for family reunification. So people who are here, who naturalized and became citizens, could petition for their families to come and become citizens. And then, so that's a plus thing for Asians and Pacific Islanders in the United States. But this time, this is the first time quotas are set to the Western Hemisphere. So in Latin America, Central America, South America, this is the first time that they have quotas. And so this is the first restrictions on Latin America. 10,000. All right, so we changed policy. So fine, we're good now. Is that right? We're good. So no more inequity, no more disparities, right? Policy, right? We're always focusing on policy. Well, the cultural transformation had already occurred. The demonization of Asians and Pacific Islanders. This was a 1902 pamphlet, the year the Chinese Exclusion Act became codified and permanent into law. This was by Samuel Gompers, American Federation of Labor, really saying that Asians couldn't become Americans because their values were different. American manhood versus Asiatic coolieism. Meat versus rice. We eat rice, so you know, we couldn't become American. And the emasculization of Asian values. This is a This is a advertisement for a washing detergent, and you can see the violence depicted, the demonization, the dirty Chinese who are filling a lot of laundry services. Uncle Sam kicking them out. And then who's allowed in? Well, everybody, but definitely no Chinamen, right? So, you know, that cultural transformation and that stigmatization was already set there for decades. So even if we repealed those restrictive legislative acts, that culture still remained. And so this is a picture I just took actually last month in San Francisco Chinatown. It's a mural. Because of all of this stigma and the marginalization and the prejudice, Chinatowns started popping up all over the country. Japantowns, Koreatowns, Little Manilas, places where Asians and Pacific Islanders would congregate and live and grow, but they were really kind of ghettos, right? They were single room occupancies and really poor living conditions. But that's how Chinatowns came up, because they were stigmatized. Okay, so now we'll get to the title of the talk, The Power of Community Organizing in Striving for Health Equity. How am I on time, Jackie? How much do I have?
18 minutes.
Okay, great, perfect. All right, so this was 1965, and so what's going on at the time? A very vibrant time of civil rights movement. Martin Luther King Jr., the community health center movement started out of that civil rights movement as well. People were agitating for their rights. They deserved dignity and respect and rights. Access to healthcare became one of those. Dr. Martin Luther King Jr. Said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And so, you know, in this backdrop of the civil rights movement, in this backdrop of all this immigration policies changing, in the backdrop of the demographics of the United States changing, you have a really, really fertile ground for this community organizing to come up. Plus, all these groups of people were forced together, and they were being oppressed all together. So, you know, what are you going to do? You're going to make it so that you can be included. The community health center movement came out of the civil rights movement, and it was really a part of President Johnson's war on poverty. In 1964, he allocated demonstration funds to establish neighborhood health centers across the United States. And what were the first two? Come on, Massachusetts. Columbia Point, Massachusetts. And where's the other one? Mississippi, Mount Bayou, Mississippi. So those are the first two community health centers started from this war on poverty, President Johnson. And to tell you a little bit about community health centers, we're really special. We're really special because in law, there's a lot of clinical, administrative, financial regulations that we have to follow. But four of the main ones are, one, we have to provide comprehensive primary care. Two, we have to provide it to anybody, regardless of their ability to pay. So you have to have sliding scale fees. Three, we're required to serve patients who are in medically underserved areas or patients who are medically underserved populations. And the fourth and most important one that I think is critical is that we are required to have a majority board of directors who are patients of the system. So 51% of our board of directors have to be consumers or users of our health center, of our services. That means we're absolutely accountable to our communities, those medically underserved areas and medically underserved populations, and we have to respond to their issues. So remember that. That's really hugely important. Because of our history and our origins of coming from the civil rights movement, you know, we're based in these four principles: community engagement, high quality clinical services, advocacy, and population health. And we do it across all levels: grassroots, community level, local level, city, county, state, and national, federal level. And it's part of our work in striving for health equity. So let me tell you a little bit about where I work, where I've been working for the past 16 years, except for the 1 year out here freezing my butt off in the snowpocalypse. I guess every year there's a snowpocalypse. Today is the first time I wore these snow boots since 3.5 years ago during the fellowship. But anyway, so Asian Health Services is no different from any of those other community health centers. We started out of the civil rights movement. We started in 1974 by student activists from UC Berkeley and community activists from Chinatown. If you know anything about the Bay Area was ripe with a lot of students in the Third World Strike agitating for ethnic studies majors. The longest student strike was at San Francisco State University, and then University of California, Berkeley had one of those too. And so these student activists and community activists did a survey of Chinatown in Oakland, found that none of these residents were getting health care. Maybe they're going to a Chinese herbalist or something, but they weren't getting good quality primary preventive healthcare services. And so they said, hey, let's start a health center. So we started in 1974. And I will say also, we started in 1974, but we started because there was already an African-American dedicated community health center called West Oakland Health Center. And we didn't have the resources to do all the financial criteria and things like that. So West Oakland Health Center sponsored us. So we owe a debt of gratitude to our brothers and sisters in the community health center movement that were more on top of their game than we were at the time. So West Oakland Health Council sponsored us. And so we started in 1974. This is an example of our general membership meeting. We hold it with a lot of interpretation, direct, current, simultaneous interpretation by different language groups. You can see some of our patients wearing their headsets and then the different language groups. We have this is our mission. It's to serve and advocate for the medically underserved, including the immigrant and refugee Asian community, and to ensure equal access to healthcare services, regardless of income, insurance, status, language, or culture. The most important part of our mission is in the first 4 words, to serve and advocate. So we provide our direct healthcare services, but we must also remember to advocate and to change those conditions and those policies that are creating those health disparities in the first place. Here's another example of and here's an example taking some of our board members and our patient leadership councils up to Sacramento to provide their input and their voice on policy issues. All right, so we have in the backdrop of Asian Health Services this civil rights movement, the students, the community activists, the Bay Area. We had some very early organizing successes. In 1978, Proposition 13 was passed, and this took away the real estate tax base that was funding a lot of the community services. As a response, the state said, well, we're going to cut all community-based contracts. That was all of the funding for the healthcare services for community health centers at the time. But we rallied. My CEO, who's still there, Sherry Hirota, rallied, got the patients, got everybody, had a sick walkout day. They closed the clinic and then had all the patients go to the county services to say, this is what would happen if you close us. No language accessibility, all the patients are waiting, and very dramatic political theater. But Proposition 13 passed. We didn't get any of our funding cut. So it's very important to have a seat at the table, or else you're on the table getting carved up. You're supposed to laugh. Okay. Okay, in 1982, at the county hospital, Highland Hospital, there was no language interpretation services. So we would be providing our primary care for our patients, but when we referred them to the hospital, they didn't understand what was going on. They wouldn't go. A lot of bad outcomes. And so Asian Health Services filed an administrative complaint with the Office of Civil Rights. And that resulted in the language interpretation unit at the county hospital. All right, 1985, let's fast forward, Heckler Report. This is the first time the United States ever commissions a report on the health status of Black and minority health. And it's a seminal report under President Reagan by Secretary of Health and Human Services, Margaret Heckler, who just died a couple years ago. This was a very important report. It sets the stage for a lot of the work that all of you do today. And in this report, 4 main things. It talked about mono-minority myth for health outcomes in Asians. It talked about the language and culture importance. It talked about disease-specific disparities and disaggregation of data. Here we go. The Asian Pacific Island minority in aggregate is healthier than all racial ethnic groups in the United States. My CEO, the docs at Asian Health knew that they may be true, but it wasn't true for the population that we were seeing. So they needed to do something about that. Cultural differences and language difficulties are major barriers for immigrants and refugees for using existing health services. All right, someone's talking about language and culture. Asian Pacific Islanders have higher rates of TB, hepatitis, anemia, and hypertension. All right, so some disease-specific disparities going on. First time in policy. There are also significant subgroups in this population: Southeast Asians, other recent immigrants and refugees, and Native Hawaiians and Pacific Islanders who have specific health problems that are not reflected in national data. A very clear call for disaggregation of data. So what was our organizing response? Well, we weren't going to sit back and let the general premise stand that Asians, Native Hawaiians, and Pacific Islanders were healthier. You let that statement stand, is all over. Our patients aren't going to get the care that they need, aren't going to get the resources that they need. So in 1986, in response, Asian Health Services with other community leaders in the AAPI community convened the Asian Pacific Islander American Health Forum. That still exists today. They do a lot of policy level advocacy on the national level. 1987, there were just a small number of Asian-focused community health centers in the United States, and they didn't have a voice in the national organization, the National Association of Community Health Centers. And so my CEO, Sherry Hirota, got together with other AAPI-focused health centers like South Cove here in Boston, like Charles B. Wang in New York, and Northeast Medical Services in San Francisco, got together and said, hey, let's create Asian Pacific Islander Community Health Organization focused on our AAPI-focused health centers. So that was created in 1987 to have a national voice in advocating for our patients. And then in 1999, there was a White House initiative executive order passed under President Clinton, recognizing the needs of AAPIs at a federal level. We had a big hand in that. So this is some of the policy organizing that had gone on. So let's talk a little bit about local organizing. And I'm going to show you some pictures. This is just to show you that organizing helps to address disparities. All right, so this was Chinatown, the intersection right in front of our clinic in Oakland. In the year 2000, an old man was crossing the street, and he got hit by a car, and he died right in front of the clinic. This old man was a patient of Asian Health Services, and he was also the father of the president of our board. So the community was really, really shocked and upset. And then they started doing some research and found that in Oakland, Chinatown, we had the highest rates of pedestrian and motor vehicle accidents for a number of reasons. The Webster Street goes from Oakland to Alameda Island, and Alameda is really a more affluent community. And so Chinatown became a drive-through, right? You're just driving through, getting home. The cultural issues of how people cross streets and language issues of not knowing, how many of you have been to Asia? Try to cross the street. Okay, so, right, so it was kind of like that. These kinds of issues, and then the language and culture, and not knowing the signages and can't read the signs. So those were some of the issues. So Asian Health Services rallied with other community groups, the businesses, the police department, and then did a whole redesign, revived Chinatown, a pedestrian safety campaign, stood on the streets, corners with volunteers, talking to people in their language, explaining how this new scramble system was going to work, created these very visible demarcations that this is where pedestrians are, and slow down. All right, so you can see this guy's almost getting hit, but now here's the scramble system. It's safer, and this is what it kind of looks like now. So it's a visual of organizing. Dr. Landry talked a little bit about the human trafficking work that I do. I'm not going to belabor that. That's another talk for another time. But it stemmed out of patients that we were seeing at Asian Health Services, Southeast Asian girls who were being commercially sexually exploited on the streets of Oakland. We did some research. Seiji and I wrote a textbook chapter about that together, and the role of community health centers in addressing human trafficking. Created a national organization to shift the framework from focusing on prosecution to actually looking at who's affected, the victims, the patients, and the health harms and the effects, looking to shift it to a public health perspective. Local, state, national organizing. We also started a California Healthy Nail Salon Collaborative. How many of you have heard of that? How many of you ever got your nails done? Come on, guys, I know. You're turning red. I know. So a lot of toxic chemicals, a very predominantly immigrant female workforce. In California, it's Vietnamese. I think in New York, it's Korean. And so looking at how do you protect the workers, how do you get rid of some of these environmental harms. And they've had quite a bit of successes. It all started out of Asian Health Services and the patients that we were seeing. Affordable Care Act, 2010. So you see, we rallied our patients to support this. Some successes, and this isn't all Asian Health Services. This is our work together. But the uninsured rate went down, and 2.5 million new AA and HPI lives got insured. These are people who can now get preventive care and services and see the doctor without worrying about how they're going to pay for it necessarily. It's huge. Community organizing. So where do we go from here? What's going on now? Oh, gosh. All right. So right now, there's a huge push to deport Southeast Asians, refugees, particularly Cambodians. These are people who were brought here as children or infants and had committed some crimes, but now there's deportation orders because they hadn't gotten their citizenship yet. So they're being deported back to a country that they don't know, they don't speak the language, and this is going on right now. I bring this up, what's the health intersection? Well, every week I have a patient who's the grandma, the auntie, the mom, the relative of someone who's being deported. And the family tearing apart of the fabric of community is real. The trauma is very real, and it's not just affecting the people who are being deported, but the community as a whole. That's a big fight, but that's going on. I just bring that up. Undocumented AAPIs. We have undocumented brothers and sisters in the AAPI community as well. This is not a Latino issue. 1.7 million undocumented Asian Americans. 1 out of every 7 Asian immigrants is undocumented. I have patients. I'm sure some of you do as well. So how are we going to protect them, ensure that they can come in and see us, get care? DACA, Deferred Action for Childhood Arrivals. So what are we going to do about these folks? And then finally, public charge. How many of you are familiar with public charge? Not everybody. Wow, I'm surprised. Okay, so public charge is huge. This is huge. The health intersections on that is very big. So the current administration posted some proposed public charge rules, which meant that they were expanding the rules to avoid. They're expanding the rules on who could be considered a public charge and who could be excluded from getting a green card if you're here legally. So the expansion criteria was if you're a legal immigrant here, you're allowed to use Medicaid, you're allowed to use Children's Health Insurance Program, you're allowed to access services. It's not illegal, it's allowed. We want to keep people healthy. The Department of Homeland Security is now saying that they can use that against you when you start, if you start to apply for a green card, to start naturalizing, to become a U.S. citizen. Also, holding money, how much assets you have in your home country against you. So under this proposed regulation, anyone applying for a green card or entry to the United States could be denied if they or their non-U.S. citizen family members use government programs. 1.4 million AAPI immigrants are in families that use Medicaid or the Children's Health Insurance Program, including 182,000 children. 983,000 AAPI children live in mixed status families. So they're American, but their parents may not be. So there's a chilling effect with this proposed rule where parents are withholding healthcare services from their kids. And there's a measles epidemic going on, right? So, yeah, so it's a huge impact on our brothers and sisters across the country. And then I'll say for the Pacific Islands in the Western Pacific, there's an agreement with the United States called the Compact of Free Association. And it applies to the Marshall Islands, the Republic of Palau, and the Federated States of Micronesia. This Compact of Free Associations means that the citizens of these three countries can come in and live and work in the United States. In exchange, the United States assumes, defense protection over this area, this region. So it's a geopolitical agreement. These COFA immigrants, they're not immigrants, but these COFA residents are not able to access services. And so that's a huge cause of disparities. And they're here living in the United States with us. All right, so when I talk about the power of community organizing and striving for health equity, you have to understand the basis for exclusion. You have to understand this is ongoing and that our fight is ongoing. We need to continue to be vigilant because it's not just about the Muslim ban or Latino immigrants. It's all of us. This is not separate from family separations going on now. It's not separate from the Muslim ban going on now. This has historical precedence, and then it's not going to stop unless we continue to organize our communities. And so it's about exclusion and inequity. But I'd say that the power of community organizing does this. Kicks it to the curb. And we turn it to inclusion and equity. And I'm going to end with this. This is my mom and grandma. And this is our public charge organizing, #OneNation. Hopefully you folks can look that up and look at this public charge rule is still going through, and we want to fight it. We had a goal for 100,000 public comments against this public charge rules. The community, not just AAPIs, but nationwide, got over 200,000 public comments. By law, the Office of Management and Budget has to review all those comments and submit responses to substantive comments. And actually, we read Seiji's, Dr. Hayashi's comments because we're doing a research kind of codifying what people are saying. And so your comments came up in some of the review. So thanks for that. And so this is the Unite and #OneNation. So let's unite, let's organize, let's fight this. And these are people that I need to thank. And I want to thank all of you. Thanks for being here.
Thank you, Dr. Chang. We'll take maybe 2 questions from the audience, understanding that there will be more time later on after our panel discussion. So show of hands, please. Or stay all the way in the back. Yes, sir.
Hi.
Which most people here at Harvard don't know where that is, but we're not part of the Compact Free Association. My question is, do you know if there are any health centers that are dedicated to help serve people from the Micronesia and Melanesia and the Polynesian areas in the U.S.? And if there are none, how can we start some in the U.S.? I don't know. I didn't grow up in America, so I don't know enough about the healthcare healthcare system in here.
Actually, you know what? There are. I'm gonna let Dr. Ghosh talk about that in a little bit. But if you go to the APCHO website, Association of Asian Pacific Community Health Organizations, there's a list of AAPI top 10% focused on Asian Americans and Pacific Islanders, and they just got somebody from one of the Pacific Islands, actually from Chuuk, I think, onto the board of directors. So there's a big push and focus now looking at Pacific Island issues. But are you talking specifically about geography in the United States? So there's a bunch in Hawaii. There's some in Arkansas, because there's a big Marshallese population in Arkansas. I don't know about Kiribati, though.
I didn't know. I'm probably the only person.
Well, welcome. Thank you. So we can talk later. I'll show you the APCHO website.
I see a question over here. Just wait for the microphone.
That was great, Kim. Thanks. Is your health center or any of the organizations you belong to doing anything on voter turnout and voter registration? Because,
Yes.
as you know, Asian American populations have pretty much the lowest voter turnout in the country.
I didn't know that it was the lowest, but hey, we got to excel at something.
So,
Yes, we are actually there. There's always a big push with health centers nationwide on voter engagement. I mean, we don't endorse any candidates or anything, but voter engagement, yes. And then I know the APCHO has an initiative on civic engagement and voter engagement. So we're working on it. We need help if you want to. Yeah, let's talk later.
All right, so another round of applause for Dr. Chang.
Thank you.
Medical students on the inpatient wards and didactic sessions. She is on faculty for Harvard Crimson Care Collaborative Clinic at BIA DMC, which is a student-led evening clinic that focuses on chronic disease management in underserved populations. Dr. Prakash is a graduate of the University of Michigan. She received her medical degree from Case Western Reserve University. And she is also a Commonwealth Fund fellow, graduate of the Commonwealth Fund Fellowship in Minority Health Policy, and a graduate of the Harvard T.H. Chan School of Public Health. And with that, I would like to bring up Dr. Prakash.
Good evening. It's a real honor to be here and to introduce this panel. We're going to start with Dr. Justin Chen. Dr. Chen is a medical director at the Ambulatory Psychiatry Services at Mass General Hospital and is an assistant professor at Harvard Medical School, specializing in the treatment of mood and anxiety disorders in young adults. His interests include cross-cultural psychiatry, stigma, racial and ethnic disparities in mental health service utilization, medical education. He's the executive director and co-founder of the MGH Center for Cross-Cultural Student Emotional Wellness, a nonprofit volunteer consortium of clinicians, educators, researchers, all based here in Boston. He delivers talks and trainings for families, clinicians, high school, and university educators throughout the United States on promoting emotional health and psychological resilience of diverse student populations. He is also a teacher and a mentor. He is the Associate Director of the Medical Student Education in Psychiatry at Harvard Medical School, Associate Director of the Principal Clinical Experience of Psychiatry at MGH, and a training mentor and co-director for the longitudinal sociocultural psychiatry curriculum for MGH and McLean psychiatry residents. He has undergraduate medical degrees from Yale University, a master in public health from the T.H. Chan School of Public Health. He completed his psychiatry training at MGH McLean in 2013, followed by a DuPont Warren Research Fellowship focused on improving engagement of depressed Chinese immigrants into mental health care at South Cove Community Center here in Boston's Chinatown. So with that, I welcome Dr. Chen.
All right. Well, that's a very tough act to follow, Dr. Chang. That's a terrific and really marvelous talk. I think I've learned a lot. So I was tasked with talking about mental health in Asian American communities in 6 to 8 minutes, and there's a lot to get through, so I'm going to do my best, but obviously we'll be around to answer questions. So I'm glad that the term model minority was already raised, and I know that Dr. Trinh will probably be talking about it as well. So I think our community has been sort of painted with this brush by the mainstream group as a demographic group whose members are perceived to achieve a higher degree of success than the population average. And I've listed some of the stereotypical characteristics here. I don't have time to get into all the problems with this, but I think some of you who are in this audience are aware that this type of stereotype tends to, first of all, eliminate a lot of the variations that occur within our community, and really, I think, serves to actually reinforce some of the silence that naturally occurs within our population in terms of hiding things that may be more shameful and really only seeing the success. And I think that's a theme that I want to really hammer home about mental health as well. And in particular, I think for our students who are growing up here and struggling between two cultures, there's a real pressure, not only to not do poorly, but also to not look like you're doing poorly, not to reveal it if you are, which is double whammy. And so actually the mainstream media seems to be picking up on this idea that the model minority may not be doing as well as we thought. And here are just some headlines from mainstream media sources. Some of you may have seen this New York Times kind of deep dive into the Boston suburb of Lexington, where there was sort of a high rate of mental health issues among students. The same reporter, Kyle Spencer, has also done a lot of interesting work in New Jersey in looking at, she hasn't really necessarily focused on cultural issues, but noticing that some of these communities where there are high population of Asian immigrant families, there tends to be a lot of conflict around kind of child rearing, mental health, et cetera, and with a toll that's taken. And I also wanted to just highlight this Washington Post article about Jeremy Lin, the NBA basketball star, who kind of came out with a very personal Facebook post that went viral. And a lot of folks were surprised to hear him start to talk about how even when he was going through high school and college, there was so much pressure. And he's seen as such a successful person, but I've seen him speak about this. It's really quite moving to hear how hard it was for him and how much he felt like a failure and how the pressure that he faced actually made him have difficulty sleeping. He would wake up with nightmares about failing an exam. And here all we see is this great basketball player. So sort of not realizing what's going on under the surface. And so just very briefly, again, I know Dr. Trinh will talk about this more, but there are very high rates of mental illness, especially in second-generation Asian Americans. But despite that, they're generally found to be 2 to 3 times less likely to seek mental health services or care. And when they do seek services, they're more likely to rate them as unhelpful. This is particularly true, they've done studies for those with more traditional beliefs. And some of this work has been actually done by David Takeuchi and colleagues right here in Boston using nationally representative data. So there are too many barriers to list. Here are some of the top ones that I see. Belief that these types of illnesses are actually personal failings as opposed to illnesses. Sort of a cultural emphasis on emotional inhibition rather than expression. You're supposed to keep it in. Very low awareness of what types of services may be available and a limited desire to seek help, as I mentioned. A lot of language and cultural barriers and a total lack, I think, of providers with diverse language abilities. And also the role of psychiatry in many, the traditional role of psychiatry in many Asian countries. I took some photos here at the Shanghai Mental Health Center, which I went to visit in 2012. It's a 2,000-bed psychiatric hospital in Shanghai. And if you can imagine, that's that's larger than MGH, all for psych beds. So it's really the era of the asylum. You're hospitalized for a long period of time. And the counseling center is actually right here across the road from this massive inpatient unit. And so the stigma is kind of embedded right there structurally. And of course, stigma and shame are huge ones. We know that for our community's face and how you appear to the community is so important. And obviously, mental illness is not anyone's idea of sort of a successful result, unfortunately. And so just in my own experiences working at South Cove Community Health Center, I learned that all the tools that we have in Western medicine are really not appropriate for this population. So you talk about individual therapy. My aunt, who's an ophthalmologist in Taiwan, said, why would you talk to a stranger about your problems? Like there's actually like sayings about this. So that one's definitely out. In terms of medications, there are too many side effects. They're addictive. People are just very skeptical, not just for mental illness, but for any disorder specifically, especially mental illness. So that one's out as well. And then in terms of group therapy, you can imagine all the problems with that, let alone even having those resources. So all of these things we didn't have access to. And so I became very interested in this, and actually I'm trying to share my passion for this with you. My entire career is now dedicated to this. After residency, I did a research fellowship where I was looking at illness beliefs of depressed Chinese immigrants in a primary care setting, actually at South Cove. And we just asked them questions about what they thought caused their symptoms, what did they think would help it. And we really, found all the things that some of you may realize, but more systematically, that they're not going to acknowledge depressed mood unless you directly ask them, in which case they will. It's not that they don't realize that they're sad, it's just that they're not going to emphasize that symptom. They are more likely to attribute those symptoms to an interpersonal or psychosocial stressor as opposed to a biological problem. And also, interestingly, we looked at rates of stigma from 15 years ago versus more recently, and found that back then they were less likely to consider it an illness, but they also had very low levels of stigma about these symptoms. But now, as they started to adopt sort of a more Western model, they were feeling more stigmatized and shamed about it. So I'm going to wrap up here by briefly sharing some of the work that we're doing to try to address this. So as I mentioned, I found that a lot of what we had to offer was not of interest to the community. And so we decided to shift our focus, and really, as in much of psychiatry and mental health, going younger and realizing that a lot of this needs to be prevention as opposed to treatment after the fact. And we realized that for a lot of immigrant families, children are the reason for coming, and that's their main motivation. They love their kids so much, and it's actually not out of wanting to torture us, but that they behave this way, but actually that they think this is what we need to succeed. And so we're going to use that motivation in a very motivational interviewing type of way to try to address mental health problems. So we try not to use psychiatric terminology and instead focus on wellness and success. And so in 2014, along with Albert Young, my mentor at South Cove, and one other psychiatrist, we actually were seeing a lot of referrals of Chinese international students who really the boarding schools in New England had no clue how to sort of manage or even engage with. And so we decided to really take an upstream public health prevention parenting approach. And we're almost 100% volunteer run and operated. Here's just some photos of some of the events. It's really fun. It actually was so terrifying the first time we did this, because it's like giving a talk for a room of your parents who are going to be like very disapproving and really have a lot of judgments about what you're saying. But we actually have found that they're so eager and interested, again, if you frame it in the right way. So I think if I were to go up there and say, we're going to give a talk about depression, no one would show up. But if you talk about, we're going to help you understand the role of emotional wellness for long-term success, then you have their ear. I think those are the rest of my slides. So I'm happy to answer questions later. Thank you.
Thank you, Dr. Chen. Next, we'll move on to Dr. Ghosh. He is the Senior Medical Advisor at the Health Resources and Services Administration of the U.S. Department of Health and Human Services, HHS HRSA, in New York. He's a board-certified eye surgeon and captain in the U.S. Public Health Service Corps. He has served in 3 presidential administrations, still there, and has worked on the development and implementation of the Affordable Care Act and the design of the National Performance Review Protocol, utilized to improve all federal health grantees. He is a nationally recognized expert in health equity. He has authored many publications focused on minority publications, including a JAMA piece entitled A National Health Agenda for Asian Americans and Pacific Islanders. His articles have been presented before Congress and the White House and have energized collaborations. You'd think we're next to a hospital. Among Congress and the White House. The U.S. Public Health Service has awarded Dr. Ghosh a rare meritorious service medal for among its highest honors for influencing progress towards health equity on a national scale. He holds medical degrees from Yale, the Medical College of Virginia, and Harvard School of Public Health, where he was also a Commonwealth Fund Fellow in Minority Health Policy. I present Dr. Ghosh.
Good afternoon. Here's the clicker. How you doing? As Kavitha said, I'm Dr. Chang, Ghosh, Senior Medical Advisor for HRSA. And before I go into what HRSA does with underserved populations, as Dr. Chang sort of introduced, let me talk a little bit about South Asian health. South Asians are a rapidly growing population in the United States. In fact, in the last decade, we've grown about 70%. South Asia consists of people from 7 to 8 countries in South Asia, depending upon how you count them. And even though they only make up from 3% of the world's land, they make up 25% of the world's population. So obviously some are going to come here. So they've come here, and what's happening is the diseases that we're seeing here are really diabetes, hypertension, cardiovascular disease. In fact, for a South Asian male, the average age of a heart attack is 40, while for a white male, it is 50. So whenever a South Asian male comes in, if you use the normal characteristics of medical, what is someone likely to have a heart attack for, they don't fit because those parameters were taken off of white men. For example, the metabolic syndrome. Metabolic syndrome is a constellation of signs in the body telling you as the physician or you as the person that this person is a setup for cardiovascular disease and diabetes. So there's increased cholesterol, increased waistline, increased sugar in your blood, increased blood pressure, decreased good cholesterol, which is your HDL. Those things sort of ring the bells that this person is set up for diabetes and cardiovascular disease. But if you look at the numbers that they use, for South Asians, you have to use much lower numbers, and they're much earlier ready for disease. Also for BMI, which is body mass index, people the standard is 25 and above is considered obese. But for South Asians, and all Asians actually, it is 23 and above. So a lot of this is out in today's New York Times in the Masala study, which from UCSF. So take a look at that and talks about that. And so Screen at 23, which is Screen for Diabetes, is now a national movement for Asian Americans and South Asians. So let me talk a little bit now about HRSA, the Health Resources and Service Administration. Actually, let me add one more thing. The reason for this disease in South Asians, cardiovascular disease, diabetes, it is all our exposure to the Western diet. We come to the United States and, there's meat and there's dairy, and my guess is that, as South Asians, we are not used to this kind of foods. For generations, we have not eaten this kind of food. And when you eat this kind of food, it really affects you physically. So what I always tell South Asians is stop the meat, stop the dairy. You will, stabilize your diabetes, your hypertension. You will also prevent 70% of cancers. Eat vegetables. Okay, so now let me talk about the Health Resources and Service Administration and Asian Americans, Native Hawaiians, and Pacific Islanders. We are an agency within the umbrella of the U.S. Department of Health and Human Services. There are 11 agencies. More famously, there's CDC, which does public health, NIH, which does bench research, CMS, which is Medicare and Medicaid services, and we're HRSA. We focus on underserved populations. And how do we define underserved? People who don't have insurance, people who are impoverished, people who are isolated physically or emotionally or geographically. So we have 90 programs, over 3,000 grantees. We serve millions of Americans, and I will talk about specific areas that we serve. So there's primary health care. Our flagship program is the Community Health Center program that Dr. Chang mentioned at the beginning. And that is a program that has over 10,400 sites across the country that serves 26 million Americans. You can go into a community health center near you and get care without regards to your ability to pay, without your regards to your insurance status, and without regards to immigration status. And the best way to find a community health center near you, maybe even in Kiribati, is you go to HRSA.gov, put in your zip code, and all the community health centers around you will show up. We also have our HIV/AIDS program. All the Ryan White HIV/AIDS funding comes through HRSA. The president talked about a new HIV/AIDS initiative in his State of the Union address. We don't have any details really about that yet, but most of that money will by surely come through HRSA. The health workforce programs are the National Health Service Corps is the big one, which takes clinicians, primary care clinicians, to work in underserved areas by helping pay off their loans. We also have maternal and child health care funding, where we give large grants, hundreds of millions of dollars grants to states to sort of trickle down in each state to work with pregnant mothers and their children. We also have rural health, family planning, program management, of course, vaccine injury, and healthcare systems, which the main program there is a 340B drug program. It's the cheapest way to get drugs in the United States, even cheaper than the VA system, the 340B system. And if you go to a community health center, they can use the 340B drug pricing program to give you the cheapest possible drugs. So, there are about 1 million Asian Americans, Native Hawaiians, and Pacific Islanders that use our health centers. And as Dr. Chang mentioned, APCHO is a body that we also fund, and it organizes the health centers. There are 32 members, community health centers that focus on Asian American populations. So this APCHO sort of coordinates them, does a lot of research, and does advocacy on their behalf. The health centers are mainly located in California, New York, Hawaii, Washington, and Massachusetts, although there's many in Illinois, Texas, everywhere. And they serve about 71% of all Asian American, Native Hawaiian, and Pacific Islander health center patients nationally, those that are specifically focused on this population. There's a higher proportion of people with Medicaid and LEP, as expected. The main diseases we see there: hepatitis B, diabetes, heart disease, cerebrovascular disease, lung cancer. And what we see in these community health centers, you have better childhood immunization rates, cervical cancer screening, colorectal cancer screening, controlled hypertension in Asian Americans specifically, and lower hemoglobin A1Cs. So to learn more about HRSA, go to HRSA.gov. If you want to learn about grants from the federal government, go to grants.gov. There are grants from every single agency, and you can sort of label which agencies you want. If you want a job with the federal government, go to usajobs.gov. But HRSA.gov has all, not only where to find a community health center by you, all the data from all the community health centers, all the health data, the financial data is all there as well if you want to check into specific health centers or specific regions. Thank you very much.
Thank you, Chandi. We'll continue on with Dr. Robert Lee Kitts. He is an assistant professor of psychiatry at Harvard Medical School. Prior to coming to Mass General Hospital, he spent 9 years at Boston Children's Hospital, where he was the program director of the Child and Adolescent Psychiatry Fellowship. Given his passion for working with underserved and vulnerable populations, he started a new chapter at Mass General Chelsea Healthcare Center, working mostly with immigrant families and their children. He is actively involved in undergraduate and graduate school mental health services as a psychiatry consultant at Bentley University. He has been engaged in LGBTQ healthcare and education since medical school. During his training, he published and presented on the risk of suicide among LGBTQ adolescents and ran a therapeutic group for LGBTQ youth. As faculty, he served on LGBTQ Advisory Committee for HMS and helped initiate the HMS LGBTQ Faculty Mentor Outlist and the BCH Rainbow Health Consortium. He spearheaded the development of the first LGBTQ clinical and scholarly elective for Harvard medical students. He has been actively involved in teaching and mentorship and has received multiple awards from HMS, including the Jonathan Boris Award, Best Clinical Instructor in Psychiatry Award, and the Harold Amos Faculty Diversity Award. Welcome, Dr. Kitts.
I'm actually going to sit. I actually wrote my talk because I have a toddler at home who's has an eye infection and is teething, so pretty sleep deprived for the last couple days. Was that? Oh, I have to turn it. Oh, fancy, sorry. So today I will talk a little bit about the intersection of being Asian and LGBTQ using my own personal story with a focus on mental health and well-being. Although every individual has a different story that is influenced by a variety of factors, I will try to hit upon some major themes that I have seen personally in the literature and as a psychiatrist who works with kids, teens, and adults. I am first generation Chinese on my mother's side, as my mother was born in Shandong, China, and I'm third generation European, as my father and grandparents were born in New York. I grew up in the 80s in Staten Island, and at the time, being biracial was not as common as today. So I'm not as exotic, unfortunately. Most people didn't know what my ethnicity was, but I do remember looking in the mirror as a young child throughout elementary school, and especially middle school, wishing I were white. It would take a much longer time to dissect all of the possible contributing factors, but certainly peer, school, and pop culture played a role, especially being called Churkel, Chinese Steve Urkel, for those. I should have had a slide for that one. Aside from Bruce Lee movies, the first major Asian film to hit the screen that I recall was The Joy Luck Club, when I was 15 years old. And the one young Asian actor I came to be familiar with was the Vietnamese boy, Jonathan Ke Quan. Does anyone know what movies? Goonies and Indiana Jones, The Temple of Doom. And then LGBTQ Asian role models and celebrities not in sight at all. I remember we were so excited when George Takei actually came out. Regardless whether I was half Asian, full Asian, it was more about being different and directly and indirectly getting the message that being different was not better, to say the least. And as such, my cultural identity and self-esteem were vulnerable despite how loving my family has always been and growing up in diverse New York City. I mean, Staten Island was a little bit less diverse. Therefore, please keep in mind the many Asians growing up and coming from less diverse and less accepting communities. Now, I compensated by being different by focusing and excelling in school. Too much so that I compartmentalized my budding sexual identity as a gay male and essentially ignored it until college. Mind you, these days, based on the literature, kids are coming out earlier and earlier, but still slower and lower in rates among Asian youth. Years later, I wrote a poem reflecting my own internal experience around my sexual identity, which was published in the Archives of Pediatric and Adolescent Medicine. Can't believe it's actually 15 years ago. I'm going to read it. And it's called Unnoticed Pain. And actually, it connects with some of the themes that were just mentioned earlier today. There he was, that 20-year-old Ivy League student who had always done well in his life. Top of his class throughout high school, made dean's list every semester in college, and already accepted to medical school. Sorry about the bragging. There he was with plenty of friends, a loving family, and a big smile. Wasn't his life perfect? Step inside his head and find a different life. There he was, that 20-year-old pathetic, disgusting gay student, lonelier than ever, crying every other night and wishing he could be someone else, wishing that the right to have a traditional family had not been stolen from him. There he was with the fear of disappointment and pain of rejection. Far from perfect, it was a life he did not want to have, it was a life he did not want to live. This individual had accomplishments that barely saved his self-esteem and had love and acceptance from his friends and family, which kept him from hurting himself. However, there are many far less fortunate. That same individual could have been discarded by his own family, harassed by peers, dropped out of school because he could no longer afford college, or attempted suicide. So please keep this in mind when the next adolescent or young adult walks into your office and appears to be without pain. The only other gay Asian individual that I knew in college, when I had to be abroad in Australia to meet a gay out Asian, he came out to his parents, and they told him he could no longer attend college if he did not take back what he said and lived a normal life. One of the things that I value within the Asian community is the importance of family, filial piety, strong work ethic, and education. But the pressure to please our parents, save face for our family as a unit, continue the family line, and make them proud can have a very negative impact on our health and well-being. A common factor in why youth attempt or die by suicide is shame and guilt. It was harder for me to come out to my parents than anyone else. The fear of familial disappointment is such a powerful and devastating tool. When looking at youth suicide attempts, there's a peak before even coming out to one's family. How accepting Asian parents of their LGBTQ children may vary, but generally speaking, it's clear that there is certainly room for improvement. Growing up, before I came out to my Chinese mother, I remember distinctively hearing that there are no gays in China, or that gay meant getting AIDS. It still exists within Asian communities, the notion that Asians cannot be LGBTQ, and that is more of a Western notion and choice. My cousin, whose parents are both Chinese, is a lesbian, lives in Flushing, New York, and she is still waiting for her father to die before she comes out, and she's over 50 years old. It didn't help when she saw how her sister-in-law responded to my coming out. The authors of a qualitative study on 50 Asian lesbian and bisexual women published in 2014 referred to a phenomenon known as triple jeopardy, where being an Asian lesbian and bisexual woman may bring on multiple additive and compounding stressors, including racism, heterosexism, and sexism. I would add quadruple jeopardy if one had mental illness, which still holds stigma among the Asian community as discussed. Another phenomenon that can occur within the Asian community, and is further discussed in this article, is invisibility. Particularly when talking about sex and sexual identity is so taboo in the Asian culture, so that many choose to stay quiet and hide in defense, such as my cousin. Additionally, invisibility also refers to the general lack of representation of LGBTQ Asians, both within the community of LGBTQ and larger US culture. 50% of these Asian women described experience in the study, described experiences of conflict with their families regarding their sexual orientation, coming out, or relationships, with 20% actually saying they're unable to indicate anything positive about being an Asian lesbian or bisexual woman. One individual stated, "My parents are not only Christian, but also traditional Koreans. So when I came out, it was a disaster. I knew that they would kick me out of the house if they knew I continued this lifestyle." Before coming out to my family in college, I wanted to establish an LGBTQ friend base as a support in case I were to lose my current friends and family while coming out. I went to our university's LGBTQ college group, and it was not the experience I was expecting, which was to be embraced by the LGBTQ culture. Wow, you're gay, that's awesome. Instead, it was a group of all-white, thin, and well-dressed females who showed no interest in establishing a friendship with myself because in their eyes, I wasn't an A-lister. I was shocked because I thought we were all D-listers being queer. Unfortunately, this is still a fairly common experience and scenario for many others, whether you are Asian, Black, Latina, lesbian, bisexual, transgender, short, overweight, or simply don't fit in. In a 2017 Huffington Post article, the epidemic, I only have like one paragraph left, even though it's not. In 2017 Huffington Post article, The Epidemic of Gay Loneliness, John Pachenkis, professor at Yale, states that in-group discrimination does more harm to your psyche than getting rejected by members of the majority. Oh, actually I have 3 paragraphs, sorry. I lied. I eventually came out to my parents my senior year of college. Despite my mother asking me to go back in the closet for my safety just once, and thinking it was just a phase for years and years, she came around to supporting both my sister, who is a lesbian, and I. Ironically, she actually loves my husband and my sister's wife 10 times more than my straight brother's wife. Thank God they're not here. 2 years ago, I was very proud of my parents for walking out of their Catholic church in Morgantown, Massachusetts, after the priest admonished those who supported gay marriage. They actually joined an Episcopal church like a mile away, and are currently babysitting my son James so I could be here. To end, despite a journey where my cultural identity and sexual identity threatened my self-esteem and well-being, I was very lucky and privileged for growing up and spending most of my life surrounded by friends and family in New York and Boston. And even though the US has come a long way with LGBTQ acceptance, there's still a long way to go, particularly with the acceptance of the trans community. Even though, it's just a side note, despite how progressive my parents are, I still have to educate them on the difference between sexual identity and gender identity and the difference every 6 months. But in conclusion, being that the Harvard community is so global, I must end by mentioning the Asian countries where being gay is still punishable by law. And those are Malaysia, Pakistan, Bangladesh, Myanmar, Sri Lanka, parts of Indonesia, and the country where Crazy Rich Asians took place, Singapore. I saw it 3 times before even knowing that. So, this list includes 3 of the top 10 most populated countries in the world. But to end on a positive note, as of September 2018, India, the second most populated country in the world, is no longer part of that list, which is a big baby step for this world. Thank you.
Thank you very much. We're going to move on to our last speaker, and then we'll have a panel discussion where we'll have some questions from the floor. Our last speaker is Dr. Nhi-Ha Trinh. She focuses her academic work on disparities in depression care for ethnic and racial minorities, issues of cultural sensitivity in mental health, social determinants of mental health, and cultural issues in geriatric psychiatry. She's a residency training mentor for the Mass General McLean Adult Psychiatry Training Program and co-directs the residency's longitudinal socio-cultural psychiatry didactic series. Dr. Trinh earned her medical degree from UCSF and her Master of Public Health at the University of California at Berkeley, specializing in epidemiology. She completed her adult psychiatry residency at Mass General McLean Psychiatry Training Program and a fellowship in geriatric psychiatry at McLean Hospital. Dr. Trinh.
How are y'all holding up? It's very hard to follow this amazing panel of speakers. So what I'll do first is, I'm a baseball fan, so this is a 7th inning stretch. Everybody stand up. Ha, that's my mom. Do a little side bend. All right. You ready? Okay, ready. So I'm also a psychiatrist. I found it really interesting that there were 3 Asian American psychiatrists on this panel. I remember, I don't know if she's here today, but a student came to my office and she was like, I just wanted to meet you, to know that you exist. You know, like this idea that Asians and mental health don't go together, right? So Justin Chen talked about that. But I have the unenviable task to talk to you about access to care overall in speed rounds, 5 minutes or less. So Dr. Chang talked a little bit about this idea of disparities, right? And so I'm a little bit of a math geek and a public health nerd, so I'm going to throw this up. How many of you seen this? Yep, all the impeachers, Commonwealth Fellows. Y'all are like, we're all over this. Okay, so when we talk about disparities, we're talking about differences in the receipt of healthcare, access, quality, whatever the y-axis could be. That's not based on patient preferences, right? It's based on larger, this word that's very au courant right now, structural inequities, right? And we've been talking about this whole evening. Now, there are different levels to disparities, right? So there's sort of the institutional level until the Affordable Care Act. There was challenges with insurance access, right? And there's also challenges with actually getting to the care that you need. And then once you get in the door, you know, are people going to be receptive to your language, to your background, to what you're presenting with in terms of your problem? And then also, you know, the relationship between you and your clinician. Are you going to be subject as a patient to discrimination or bias just based on the way you look? And I would say, unfortunately, for a lot of minority populations, this is a challenge, and it definitely is a challenge for the Asian American population. So, what are some challenges? Because let's just say axiomatically there's going to be barriers to access of care. And what are those challenges? The first is measurement. It was really amazing to me that in 1985 that Heckler Report was talking about how we need to disaggregate these populations, right? Because we're seen as really monolithic, right? Crazy rich Asians, right? Let's talk about Singapore. I was like, none of my Asian relatives look like that. So we are very different. I mean, even the stories that our panelists and our speakers have talked about, each of us has an individual story. I'm a psychiatrist. I'm very interested in those stories. But the challenge is that when we get this data from the federal government, unfortunately, or even from state governments, we're lumped, right? We're very much lumped. And that sort of belies the diversity and some of the socioeconomic challenges, immigration challenges for this population. With the Affordable Care Act, yes, Asian Americans, and we've gotten much better insurance access and coverage, but we're still underinsured. And because because after the 60s, with all these exclusion acts, suddenly people started pouring in, my family included. We're a proud refugee family from Vietnam from the 70s. And then these are the newest immigrants. So, they're going to scrimp and pinch. They're not going to spend money on insurance. So people are still underinsured, even with the Affordable Care Act. Finally, we sort of touched on this in various points today, sort of language and cultural barriers, right? So you think about the limited English proficiency. I think there's like 30% of this population qualifies as being limited English proficient. 70% say that English is not their first language. We talked about discrimination and bias based on the way you look. Stigma surrounding disability as a whole, right? Like not going to the doctor, not wanting to trouble your family. And then when you talk about mental health, that's even a larger case. It's sort of like either you're crazy or you're not crazy. So you'd rather be not crazy, right? So this idea that you could seek help is a real challenge. And then this model minority stereotype. Ironically, I had to send my slides to Teresa this morning because I misspelled stereotype. It was sort of like, kind of like a brain fart kind of thing. And I thought to myself, well, I'm not going to, fall into that model minority stereotype. But the challenge, well, maybe I would, because it's like, oh, it's not a math problem, right? So, but the problem with the stereotype is that both negative as well as positive stereotypes have like an effect on us, right? So, negative stereotypes, of course, but then also the positive stereotypes that sort of dehumanizes us, right? So it makes us into this like homogenous mass where, people don't differentiate who we are. I have two stories about that. One is my name is Nhi-Ha Trinh, difficult name, and I have a colleague, Chang, who's in the same group, right? And Trina is like a very nice person. I am not a nice person. She's very sweet, oh, how are you today? I'm just like, hey, how's it going? I like bust past. And people cannot tell us apart. Like, it's really kind of, but the thing is, it's sort of like this idea of, we're all the same. You're all high achieving Asian women, right? What's the problem with that? The problem is then your individuality gets lost, and that has effects not only on your emotional health, but I think overall on your physical health as well. I also joke now that it's actually a good thing because that means that one person is doing two people's work. Anyway. All right, so solutions, right? So, I didn't make these solutions up. These are part of the literature. This is part of the parlance. I just want to sort of bring together these concepts for you all today before our discussion. Of course, we want to collect robust data. I would say that's very hard to do, but it is an aspirational goal. We want to provide affordable access to healthcare services for all Americans. I'm raising up my lefty flag. I think we should have Medicare for all. We want to remove some of those language and cultural barriers, right? Especially for mental health services, but for all services. And I'm really happy that we have community health center representation here to sort of champion that. We want to promote cultural competency. I put competency again in quotation marks because I think that's an aspirational goal. It's like becoming enlightened, like the Buddha. Like one day you'll be culturally competent and you'll just disappear, right? Because we're all aspiring to that, myself included. We all have our blind spots. We all have our biases. It's better just to confront them, stop the guilt, and move on and learn. And we want to have diversity among health staff, not just because, I'm going to take care of every Vietnamese person in the Boston area, although everyone does call me, but sort of this idea that diversity for diversity's sake is important, right? The more different voices we have in the room, different perspectives, we actually make better decisions. Might be more fractious in the meantime, but they're better decisions. And also it's this idea of representation. As Dr. Landry would say, you can't be what you can't see, right? So those students who want to come talk to me and just like look at me as a museum relic, oh, it's the Vietnamese psychiatrist. Come on in, because this idea that we want to support each other is very important. All right, and I was just reading this yesterday. I was like kind of Googling. I love to Google. So I was looking at this and I was like, this is it. These are the kinds of solutions we need. Thank you very much.
So I'm going to ask our panelists to come to the front, and we have about 15 minutes for questions and answers, and then we'll finish up with Dr. Hayashi.
Sorry.
So after such a broad and robust conversation, I'm sure there are a lot of questions out in the audience. I think we've had two people kind of moving around with microphones. Anyone have any questions? Can we give him a microscope?
Hi, everyone. Ooh, I'm so sorry. Hi, everyone. Thank you, all you guys, for the amazing talks. My question is, what is your advice for someone who's young, in their 20s, who want to start a career in battling disparities in healthcare, but have no idea where to start? It's very broad, I know.
I think networking. It's amazing. Like even any of us, that's one of the best things you can do. Meeting people that are doing really good things and putting yourself out there and saying, hey, can I meet? This is who I am. Any of us, anyone that you see doing wonderful work, just put yourself out there. The worst that could happen is they don't respond, and really establish those relationships.
Sure. You mentioned something that's so broad that I think this stage you need to learn about what exactly health disparities means. It means different things to different people, different groups have different focuses on it. It's huge. So find out also different levels, like whether it's government or community-based or local. Just learn what it could be and find the ones that are interesting to you. Not everything's going to be interesting to you. Sometimes it's based on your own ethnicity and your own experiences. Sometimes it's just based on interesting research that's going on. Use this time to learn, find out what's interesting to you, and then hone in on that. Because I think it's such a broad area, and you'll go out there and get lost for the first year. But just figure out what it is, and then go from there.
Somebody said apply for an MPH, Master's in
I've been told that the MPH is the only degree that you can get where your salary actually goes down, and it's totally worth it. It's great people.
Next question.
Thank you. One of the things that I really struggle with as an Indian American is getting involved in health justice activism without co-opting other minority groups' movements. Could you talk a little bit about, I guess, coalition building with other ethnic minority groups while still kind of representing that Asian, South Asian population?
I'll talk a little bit about coalition building, not necessarily South Asian, but I'll give you an example. The California Healthy Nail Salon Collaborative started because of our patients who are Vietnamese, and we were seeing a lot of health effects in them. So they organized the community, started going out to salons, doing that ground level meeting and greeting with the owners and the workers and talking about health effects. They've since worked with Black Women's Wellness and Mujeres Unidas, and different other labor organizing groups. The Black Women's Wellness Group focuses on nail salon products hair and beauty salon products in African American community, and they've developed a national coalition. So, I would say it's not necessarily about co-opting, it's about working together, understanding the issues and seeing where you intersect and supporting each other, always supporting each other. It's not about credit, it's not about, who's getting more lion's share. It's working together and using that to build a movement building.
And just to add to that, again, everybody wants partners. And if you're new to this, start working as a partner on some other issue that's close to what you want to do. And then you get these natural partners because they know you are a respected person that's not just a stranger who's coming in for your own needs. You're here to help everybody. There are a number of groups that work on already on social justice for South Asian Americans. Work with them because they also already have the partners. You don't have to start on your own. You don't have to build the wheel from the beginning. It's already out there. Just join a movement. You're not co-opting anything. Don't worry about those things. People just want partners and friends that they can trust to be part of this movement.
I guess also if you're interested in like a specific other like group that you would want to work with, you can always make outreach and then see if you can like attend one of the meetings and then get to know them and know their mission and really develop relationships face to face.
All right, let's move on to the next question. I think there was someone here on this side, kind of towards the middle.
Hi, my question is about mental health. Like as a Asia, like patient from Asia, mental health topic is a very taboo, and even patient has like see the primary care see like symptoms with the patient, like need really like a counseling or referral to mental health. Like a patient kind of like not to go, you know, even like they make it to like first appointment, but it's very hard like not describing like really feelings, like rather than describing like body symptoms, like I have a headache or stiffness of neck, you know, how we interpret in that medical, like mental term to the patient, like a refugee patient or immigrant patient, where they don't know about even the mental health exists, like how we like do that, like a gap between that, like make patient to come to the appointment or realizing like behavioral health is like you can get the help, how like we work on that. So that's the question.
Could you just clarify the question? It's so you're saying it's really hard sometimes to sort of talk about mental health issues or
and not like how you like you know how you challenge like it comes like if you have like encounter any of them, how you do that, like sometimes they're not understanding, they come to first counseling appointment but not really understanding, like if you say, oh, how you feeling or how you are down, like they're not saying, oh, I'm feeling sad or I'm down, but you know, I say, I have dizziness, I have severely headache or neck stiffness, body aches and pain, like how we interpret that physically symptoms to like mental health, like the issues, others like physical, like symptoms. So that's.
I'll start, and I'm sure Dr. Trinh will want to say something too. So I have two stories for you. One is that the first time my mom went to see a counselor, they advised that she get a divorce, and she never went back. And so I think, you know, I think I had talked about engagement before, and I think that's actually incredibly important. It doesn't really matter what we think is going on with the patient. It actually matters probably more what they think. And so trying to meet patients where they're at. If it's that they have a headache, that's okay. We'll talk about the headache. You know, I think, and then you, as it's a principle of mental health, you leverage the relationships over time. They recognize that you're someone who actually does care about them. And whether it's the headache that then is somewhat caused by interpersonal tension, and that's what they want to call it, that's fine. Actually, one of the things that we've worked on is developing models that clinicians can use, or educators with students. So it's very similar. They don't want to say, I'm depressed. So we talk about sort of a stress model, right? And we talk about how any animal, including a rat, if you were to sort of stress it beyond a level at which it can actually sort of balance that stress, will have symptoms that'll look a lot like depression. Sort of not eating, not sleeping, sort of losing interest in things. And so we sort of normalize it and say, you know, everyone agrees that stress is important. And so if you can use a term like that, all of a sudden you have buy-in versus, oh, you have this like mental illness and you need to see a psychiatrist. So it's a little, it's not being disingenuous, but it's sort of being flexible, I guess you could say, and meeting them where they're at. And the other story I wanted to quickly mention is I did, during residency, I was fortunate to work at Revere Counseling in Revere, Massachusetts, which has a very large Cambodian population. And it was so eye-opening for me. So I think for all of you going through clinical training, go to the community health centers and work with the population. What I learned there is that that clinic was run by 2 bilingual, bicultural social workers who spoke Khmer. They were from Cambodia. And it was really interesting. It didn't look like the psychiatry that I was trained in at MGH. It was, they were sitting and chatting. You know, how you doing? How's your sleep? How's your son? Is he still in that gang? And then the prescriber, all the prescribers were not Cambodian, but we would come in at the end. And then that social worker had gotten all the information, but not in a way that was clinical. It was just, you know, what's your life like? And then, you know, maybe it's the sleep is not good or there's more anxiety. They were all on a very similar regimen of medications, and so we'd adjust those. And what I realized over time, that community health center was also where they held their annual New Year's celebration, so it was really part of the community. And we also went out and did home visits. We went to the temple, and we learned how the role of religion was to help people recover from mental illness and be reintegrated. So it was like, wow, that's like not what we were taught in the textbook, right? And that's okay. You know, you meet them where they are at, in their homes and in the community, and then you can do a lot more good than if you sit there in your ivory tower and say, if you don't come to me, then you don't get help.
I'll just piggyback a little bit about, yeah, you have to check your arrogance and go slow. So it's like, so often it's like the thing that can go wrong is you meet them for an hour or even less, and then you want to prescribe a medication, and that completely like turns them off. So it may take like multiple sessions just to go slow and get to know and learn from them and not push the medication, because that's probably one of the easiest ways to destroy that alliance. Is pushing the medication and diagnosis, but go slow, learn from them, and around the common goals, whether it's sleep or stress, or that will keep them coming. So that's, yeah.
Yeah, I would just say, you know, it's a challenge because we are steeped in this Western culture, right? So all 3 of us are trained in a particular model of psychiatry, and that's a very Western-based model. And Justin Chen actually gives a wonderful lecture where at the end he challenges this idea of our diagnostic and statistical manual and says, is this all culture-bound? You know, right? So is depression just, you know, a curiosity of the West? So focusing more on the distress, what's going on with the individual, how can we help make their lives better and have them be their best selves, and what's acceptable. So really that idea of meeting them where they are.
Great, thank you. Any additional questions? Now we have several.
Hi, thank you so much. I had a question about the screen at 23. While I think it's really wonderful that a lot of the times when we talk about health disparities among minorities, Asian Americans are usually not included in the data. So it's been really interesting to see that guideline change. I wonder what your thoughts are on us falling into the same traps of homogenizing Asians as a whole and losing that distinction between East Asian, Southeast, South Asian, but also the distinction between first, second, and third generations and how culture and diet change across generations. And additionally, how this lower BMI screening feeds into potential stereotypes of especially like Asian and young Asian women expected to be like skinnier without, and then kind of feeding into that concern as well. How do you practice these new guidelines while keeping those concerns in mind?
I mean, I think you have to first always look at the patient as an individual without the grouping of Asian or whatever. Just look as an individual, because, you know, the word Asian is really a political term that we use, and to include that, you know, people coming from so many different countries, so many different lifestyles and foods and religions and languages, that we're lumping them together here as Asian for political purposes because numbers have advantages. But I think as a clinician, you have to really look at the person individually, and you as a person have to look at yourself individually. I understand the foods that you may be eating are different first, second, third generation. Your other habits are very different first, second, third generation. Not only that, but where your roots are. It's so complicated that, you know, screen at 23 is obviously a broad brush, but we need to have a broad brush for clinicians in America to start with. You know, everybody in America looks at large numbers like screen at 25 because BMI 25 is obese. Everyone knows that number. So let's start with these baby steps. Screen at 23 is a great guideline to start. but you have to advocate for yourself and your family and educate clinicians that this is a great guideline, but this is who I am individually.
All right, I've been told we have time for one more question. Just to make it fair, how about we take a question from this side of the room? Okay. Yes.
My name is Monica. I'm working with the Medicaid program here in Massachusetts. I had a question about, we are doing a study looking at contraceptive use, and we were able to take data from the Title X programs, stratify it by race, ethnicity, and language, and feed it back to community health centers to have them look at the equity of practices within their organization. And when there were significant differences with the Asian population in using most and moderately effective contraceptive methods, they were like, oh, well, this doesn't matter because we treat everyone the same. It's just how they behave. And so how do we get models that actually work, say, for maybe a Vietnamese population or a Chinese population when we're getting kind of feedback like, oh, this is just how it is with those people?
A straightforward last question.
Wait. So, Dr. Lay, what your question is, or your statement was that the community health centers are saying that they're treating everyone the same, and within the stratification of the patients, you're seeing some differences. They're not getting contraception.
They're not getting contraception. They're not using most and moderately effective methods.
Did you? I'm just curious. Did you stratify by the health centers that are AAPI focused and the ones that are not?
Well, the one that is within Massachusetts. Yes, it is. And specifically, we gave that feedback to that health center specifically around not really any medium method or moderately effective method. It was all either like larks or nothing, essentially. Yeah, but they also gave us that same feedback. They really said, we don't really know. It's interesting, but we don't really know what to do with this data. You know, and I was looking for models in which maybe something was different. They did something different, but I can't find like best practice Asian Pacific Islander models out there. I don't really know what to say.
Yeah, I don't know what to say either. But actually, we should talk offline, and that could be something that's an area of interest. And because there's probably no data on that, right? It probably hasn't been studied. So I don't know.
Kind of speechless, actually. Sorry. I'm so speechless, I'm pressing their microphone off. It kind of reminds me, Justin Chen and I, we're co-directors of this series together, and we do a sort of more individually based, sort of this idea of what do you do when people make racist or microaggressive comments? To me, that comment was very racist and microaggressive. So I think it left me kind of, whenever I get really confused, like, what the heck is going on? I think to myself, there must be something there that's offensive. So putting my shrinky hat on, I would say, maybe talking to the leadership and say, what do you mean by that? Like, can you say more? Can you explain what that means? We need to act on this. This is a public health issue, potentially, a women's health issue. So I would kind of put it back on them, like, help me understand what that means, because then there could be a little bit more of a dialogue about what their barrier is and how you can think about addressing it. That's my thought.
Well, thank you. Thank you, the members of the audience and the panel, for a great conversation today. We're going to conclude with some words by Dr. Hayashi. He's the commentator this evening. He is the Director of Medicine at the Human Diagnosis Project, HumanDx, a worldwide effort to enable more accurate, affordable, and accessible care for all. He's a board-certified family physician at Mary Center, a community health center serving medically vulnerable individuals in Washington, D.C. He's an experienced leader in primary care, quality improvement, and health policy. Prior to working at Human DX, he was the Executive Vice President for Transformation and Innovation at Unity Healthcare, one of the nation's largest community health centers. He also has served as the Chief Medical Officer for the Bureau of Primary Care at HRSA, where he oversaw clinical strategy for the $5 billion health center program that cares for 26 million people across the country. He has spent a decade in academia teaching and conducting research on clinical medicine, public health, health policy for medically vulnerable populations at Georgetown and George Washington. He has a degree from Vassar College in studio art, received his MD with AOA distinction from Albert Einstein College of Medicine, and completed his residency training in family medicine from UCSF. And he has an MPH from the Harvard School of Public Health and was a fellow at the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. I present Dr. Seiji Hayashi.
All right, I'm the last, and before you guys can get some refreshments or go to dinner, but I have the unenviable job of sort of coming up with responses to what everybody said, and whenever I think about a commentator after a panel like this, I'm thinking, and I was telling Justin earlier that these are usually, older people who are wise and whatnot. And then I just looked around the room and I was like, oh my God, I'm older than most people here. I have some colleagues around my age, but yeah, so I guess I will try to impart some of the insights that I've kind of gained today. I'm not going to summarize things, but here are the things that I'm taking away from today. First, that personal stories are powerful. You heard a lot of personal stories today. And I know that working in policy, that stories like the ones you heard today really change the minds of policymakers, decision makers. We have to use it. But, often we don't. And I think that, Asian Health Services, Kim and her CEO, Sherry, they're so good at telling stories and really mobilizing the community. But one of the things that I heard through these stories was that otherness is devastating, right? Feeling like you don't belong. It's really devastating to not only the person sort of feeling that, but it is used as a tool to oppress, right? And I think that the stories that people tell need to be told so that that doesn't happen and it doesn't get used in that way. The other thing that kind of got me thinking about what Dr. Chang began to, in the first part of her presentation was about history. There's a lot of movement to actually erase history, right? And I think that remembering history is one of the most important things. When I think about all the historical things that happened to Asian Americans and Pacific Islanders, I didn't know half of these things that I learned today. But then, do people know about the Native American genocide, about slavery, about the Holocaust? There's so many different horrible things that happen, and people are trying to erase that history. And I think through stories and documentation, we need to make sure we don't forget that. Another sort of thread that I heard is about data. And that data is neither good or bad. It's really about how you use it, some of the perspectives. I was thinking about the fact that I wear, to show that I'm older than you guys. These are progressive lenses, right? Yeah. They make you look at things lefty. No, I'm just kidding. But the issue with these lenses is that I can see from the top very far and clear, all of you in the back. But if I try to use that same, lens close up, I can't see anything, right? And that's why I use my reading part. Just data is similar in that when you focus on something, you're not seeing something else. And I think that's one of the things that I heard today from the speakers, is that when you look at data, you're going to be blinded by certain things. The disaggregation of data among the Asian Pacific Islander community is so important, right? But not only data that we currently have, but putting on the lens and perspective, our own culture and language and experience to collect that data is going to be even more important. And so, all of us sort of advocating for the collection and disaggregation of data, I think is going to be really important. We heard from, questions about coalition building. We heard about coalition building from Dr. Chang and others. I think one of the things that I learned today and was really thinking about is that, we need to rise above our individual sort of issues, and then if we're going to come together. If you rise above high enough, you're going to have enough sort of commonalities with people where you can work together. And we heard that from how Asian Health Services worked with the African American Serving Health Center. And so, finding that commonality is really important. We heard, I think, a number of the panelists work in community health centers. And when I think about the value of a community health center, I mean, there's so many, but HRSA, with its funding, basically created an infrastructure for access to quality care. And when you think about infrastructure, you're thinking about things that are stable, long-lasting, like bridges and roads. It's something that you can rely on. And I do think that community health centers is that. But what's really important is that these bridges and roads, over time, they deteriorate. So you actually need new people, new funding, new resources coming into it, and that's where policy is so important. And the fact that the HRSA puts in $5 billion a year to support this infrastructure is really remarkable, right? And that we need to actually advocate on behalf of communities through federal programs and policies. The next thing that I heard was about we heard a lot about mental health issues, and I was thinking about, wow, what Dr. Trinh said about, 3 Asian psychiatrists here in one room. I mean, that's more than probably the entire state of North Dakota and South Dakota combined. And no, I'm serious. It's really true. A couple of years ago, several years ago, I work in Washington, D.C. in a community health center, and I was seeing a Vietnamese woman with post-traumatic stress disorder. And I really wanted to find a Vietnamese-speaking psychiatrist. And I searched for 3 weeks, and I finally found one in Northern Virginia. One person who speaks Vietnamese, who's a psychiatrist, but then she didn't take Medicaid, the insurance that the patient had, and I was devastated. But the fact that access to mental health care, especially among Asian Americans, is really challenging, is a major issue. But one of the things that I began really thinking about with mental illness and mental health is that it impacts everything, right? Mental health impacts everything. And if you think about the fact that, we talk about how, we ask people about wellness. How well do you feel? How healthy do you feel, right? If you're not mentally well, you're not going to feel well. You're not going to do well. It's going to affect your job, your education, your family, your physical health. And I think that if we can crack this nut of access to quality mental health care, it's a game changer for the entire world, right? And so we really need to work on this all together. And so I think that, I'm just awed at, all the stories we heard today, the issues that were elevated and raised. And so in closing, I just want to ask everybody to, help me thank the panelists and the keynote speaker.
What a wonderful set of presenters that we had today. Again, another round of applause for our presenters. I just want to call your attention to a few items. Number one, on the back of the brochure that you're handed is a list of some of our upcoming equity and social justice lecture series events, including an event on March 7 with our Alvin Poussant visiting lecture. And Dr. Valerie Lewis, a graduate of Harvard Medical School, will be coming to talk. We have events October 23rd, the Howard Dorsey Still Lecture with Dr. Otis Brawley coming from the American Cancer Society. And then we have our faculty, Leadership and Faculty Development Program Conference, which is going to include a number of talks, including one on maternal fetal health, our discussion around digital health, and a career development training workshop on time management. So if you're available, you'll be seeing information in our mailings and through email about these opportunities. I just want to say thank you to our co-sponsors, the Association of Harvard Asian and Asian American Faculty and Staff, Harvard School of Dental Medicine, Office for Diversity and Inclusion, Harvard T.H. Chan School of Public Health, Office for Diversity and Inclusion, the Commonwealth Fund Fellowship in Minority Health Policy at Harvard University, the South Asian Medical and Dental Association, and a special thanks to Raj and Kathy for your help with moving around and keeping us on track today, and the HMS Office for Diversity, Inclusion, and Community Partnership team that was here. And you met many of them at various points, including Ying Wong, Teresa Carter, Jackie Wright, Christine Colasino, and Faryar Jim. So thank you to all of those individuals for helping us to execute this wonderful day. We have some receptions in the front. Please come and enjoy. This is a time to interact, to engage, to meet our speakers, exchange business cards, to network. And again, thank you for your time.